So thank you very much. Good afternoon. We're going to talk about biceps tenodesis. Why, when, and how. So those are my disclosure. Again, Lip and Castle in 1943 stated that maybe the long head of the bicep was an unimportant vestigial structure, something like the appendix of the shoulder. You only would notice if something goes wrong. But in fact, we had a lot of papers published, a little controversial as well. We don't know exactly which of those functions are the most important, but it seems like it depresses the humeral head and stabilizes anterior forces, helps on accelerate and decelerate the arm on throwing athletes, increase anterior and posterior stability, resist torsional forces and proprioception. And when we think about those functions, we begin to think that when we don't know what to do in the shoulder, we take the biceps and do something. So we have a biceps to make better reinforcement, trying to substitute a superior capsular reconstruction, or we have a bicep that can go in a dynamic anterior stabilization or to enhance the rotator cuffs. So the biceps is like the joker of the shoulder for using and the villain of the shoulder for other things. But we have to understand the anatomy, and I will try to make you guys understand why I think that we should think independent on the biceps. So people think that, well, there's an interarticular problem. But in fact, the problem can and might be extraarticular in most of the cases. And it's crucial to understand, because if you get in the arthroscopy and see, whoa, my biceps is so nice, it's white, it doesn't mean that it doesn't have a problem outside the joint. And this was very nice described by Professor Young Ri from South Korea when he analyzes the hidden lesions of the extraarticular biceps after a subpec tenodesis. So he took the biceps that was resected after the subpectoral, and he evaluated, and he saw that in only 20% of the cases, the biceps will be intraarticular. The problem will be intraarticular. So most of the cases is not like this one when you see, for example, a red area here, an inflammation area, because most of the problem will be outside the joint, and then you're not going to see. And if you're not aggressive, if you're a member of the non-biceps killer society, you probably will leave alone problematic biceps. So let's create some scenes, and I will go for the first, which is the most common, and in the end address the third one, which I believe is more important. So that's a typical 65-year-old guy, left-hander. He plays the tennis and violin. He has shoulder pain for more than 6 months. He cannot do sports. He cannot play his violin. He has a cuff tear, and most of the cases he will have inflamed biceps together with some sort of a subscap tear. So you go for the procedure. Most of the times you're not going to indicate the procedure because of the biceps. You want to repair his cuff, and when you get there, you have to decide, leave the biceps alone or not. Most of the people nowadays will tenodese the biceps together with the cuff repair, but that's not the primary problem that I want pointed out. I want to share with you guys my experience with isolated biceps lesion. Let's go for a second scene, which is a male, 52 years old, right-hander. He's a surfer. He had a shoulder dislocation with multiple intraarticular lesions. He had a banker lesion. He had a cuff tear. He had a subscap tear. And he's painful after a couple of weeks. He's clicking, he's popping. And when you get inside his shoulder for a full thin repair, for everything repair, you see a type 4 slap lesion, a real slap lesion. Because we know that type 1 and type 2, most of them are nightmares from the surgeons. They are not real. And type 3 and type 4 normally are real. So that's a type 4, and that should be addressed by probably a biceps tenodesis, and then goes for the preference. My preference is always a subscap, but that's individual. And then we go to the third scene, which is the one that I've been seeing a lot. This is a male. He's 52 years old. He's a right-hander. He doesn't have a problem in his cuff. He doesn't have instability. He has 4 years with the left shoulder pain. He got a rehab injection. He got anti-inflammatory with just temporary relief. He has a normal cuff, and his bicep signs are always positive. And the doctors, he said, well, you don't need a surgery. You don't have a problem in your cuff. Or you need an injection, or we can do some cortisone. And he's 4 years. And then when we decided to do the procedure, we get this kind of This kind of problem. So you see that his bicep looks horrible. Most of it is outside the joint. Most of it's in the and he's like for 4 years. So why wait 4 years to do a procedure that can solve the problem? And we know that we don't have to be aggressive most of the cases, but we also don't have to wait like 1, 2, 3 years with a young guy who wants to do sports with a typical isolated biceps problem. So I would like to divide that in, the first one is like overload. Normally this patient had muscle imbalance, has a scapular dyskinesia, and like described by Dr. Peter Millett in 2017, it looks like an inflamed sheet, like a Decker-Vein syndrome, who can constrict the long head of the biceps inside the groove. And then we have the other two kinds related to the cuff problems and related to slap lesions. So clinical issues, we have anterior pain, but anterior pain we can have in many, many different situations. It's important to check why maybe this biceps got inflamed, if it's a sort of a trauma or a slap lesion or just muscle imbalance related to scapular dyskinesia. Try to address first conservative. And also, for me, it's important to show what I call the rotation test, which means if you just palpate the long head of the biceps with 10 degrees of internal rotation, and he said, well, it's painful. Many things you can press in front of the shoulder, and the patient is going to say, well, that's painful. But if you do the rotation test, you make an external rotation, you keep your fingers in the same place, the biceps will rotate with the arm. And if you press there, and it's better. And then we go a little bit lateral and say, well, it's painful again. Then you know that he has bicipital groove tenderness. Although you're going to be saying that many people who does not have bicipital groove tenderness are painful. So you do the rotation test, you do the speed test, you do other maneuvers. I don't want to show all of them for you because you were aware of that. Imaging, most of the times, can show associated lesions. And some sort of edema here, inflamed tissue. And you can imagine that's not an open room. That's like a carpal tunnel. The biceps is inside, and the biceps is completely compressed by this fluid, and it doesn't leave so naturally alone. So imaging can show those problems and help on the diagnosis. So now we have the bad guy, which is the Mr. Long biceps, and we have the good guy, which is Mr. Shoulder Surgeon. And then we have to decide if we're going to kill the surgeon or if we're going to save the shoulder. So you have the options of a tenotomy, which is like throwing this guy all the way to the end, or Tenodesis, where you put this guy inside a wall and fix them in a place. Okay, we have to decide that. There is a lot of paper, there's a lot of publishing literature showing that biceps tenotomy versus biceps tenodesis. It depends on age, it depends on what the patients want to do. Some patients have more groove tenderness when we do the tenodesis, but is the biceps still in the tunnel, or the biceps is all out of the tunnel? So by one side, you can say, well, a tenotomy leads less pain than a tenodesis, but it can lead to residual pain, pulpi deformity, cramps. So decisions will go always to the surgeon experience, individual expectations, age, demands, and etc. So for the stenotic long head of the biceps, tenosynovitis, like described by Peter Millett or like reinforced by Peter Miller, I believe that most of them come from some overload, muscle imbalance, scapular dyskinesia, and of course I will try to treat them conservative with any kind of anti-inflammatory or even a cortisone shot or general cortisone and scapular stabilizer, better posture, muscle imbalance. But for how long? How long are you going to keep this guy treating? How long? You need to, when you see a patient, you need to give him focus. The patient has to understand what he has and has to understand what he's going to do and until when. Don't leave a patient eternally in physical therapy, because in some point he will going to look for some person that will decide what he has to do. So in general, what I do is give 3 months of physical therapy, and I try it during 3 months. After 3 months, if he's getting better, if he's improving, okay, we can keep on leaving him in physical therapy. But if he's in the same place, there is no reason for us, if he has an isolated, very clear biceps lesion, to just perform the bicipital tenodesis. So again, if conservative treatment fails, tenodesis is normally better than tenotomy. Those group of patients tend to be a little bit younger. And my personal preference goes to subpectoral tenodesis. There is this nice paper published in Arthroscopy in June 2017 from the Peter Miller group. showing good results with this kind of procedure. And also, there's other papers comparing supra versus subpectoral biceps tenodesis. They have similar results in pain relief. More complication with the subpectoral. There are some described humeral fractures related to subpec. I never had one, and I did probably a couple of hundreds subpec tenodesis during my life, and unfortunately I never got, with the technique that I use, I never had a problem. And we have also this paper, which I think is nice from the JP Warner group, showing that if we release the transverse ligament with a suprapectoral biceps tenodesis, the result will be better. And it makes a lot of sense, because it is exactly what you do when you do Decker vein release. So you're just decompressing. So, and where should you tenodesis the biceps? That's a discussion. And the group from Evan Flato has published in 2011 a paper who's showing that most of the cases will have more symptoms if they are done in the proximal part. And he considered, it's very important, supra and subpectoral as distal. So he will say, well, do it suprapectoral or subpectoral. Try to avoid doing the joint, inside the joint, because you're still going to have a lot of biceptal tissue getting in the groove. Again, another paper showing, that's come from the Netherlands, showing good results with subpectoral and better results from the subpectoral, but non-statistically significant. Another patient showing better results also with a subpec, but again, non-statistical significant. That's the technique that Dr. Simmer, my friend Jair Simmer from Brazil, do. He does always a suprapectoral. Myself, I believe that it's a pretty demanding technique. It takes a little more time for you to find the bicep in the groove. And I'm always headed to understand that subpectoral, I make myself safer. That's the way I think. There is a tunnel here. There is a tunnel here. There's option to put that intraarticular, suprapectoral, or subpectoral. And I'm sure that going subpectoral, I'm going to be out of the sheet. Normally I use a bottom, and the bottom, I like to use it in two corticals. You can use it only in one cortical. That's the technique that we've been doing for many years. We can do a very, very small approach. That's a 1.5 to 2 centimeters approach. Okay, maybe it's exaggerated. You can go to a little bit more. It won't make a difference. I like to go a little bit more lateral than most of the people, because I tend to see better the junction. The trick of this procedure is really to get under the pec major. You're going to be able to find the best spot for you to fix that. You can do a baseball kind of suture there, and use a bottom bicortical. I like to use bicortical. You can use unicortical. There is other devices that can be used to make a nice subpectoral tenodesis. The post-op, if we do a rotator cuff repair together, the rotator cuff will lead. So the time that we're not going to do active motion is going to be related to the time that we need to healing of the rotator cuff. But if isolated, if you're just doing an arthroscopy, or maybe an acromioplasty if you think it's important, or maybe some cleaning, but in isolated subpecs, I just use a comfort sling. I allow the patients to do flex and stand without, of course, carrying any kind of weight. I always tell them not to do any acute motion like that, because I don't want them to make any risk in this healing. And it's amazing how the biceps can very, very fast heal in the humeral diaphysis, even if you do just one cortical. I just let him load it progressively after 2 months, and no arm sudden movements for 3 months. Then normally those patients with 3 months, they are completely normal and ready. And they have this perception that the pain is gone in a couple of days after, even the day after. See, this pain that I have, it's gone. It's not there anymore. I feel it's sore. You know, I got an operation, but it's not there anymore. So my take-home messages in that presentation is that, first, when you see isolated biceps pain, just be sure first that it's the biceps and not other structure. Anterior pain can have different causes. Try to differentiate those three causes where the biceps can be affected. This synovitis, tenosynovitis, cuff tear, and slap lesion, the real ones. Don't be careful. We have to remember that Stephen Snyder published in his first article, 700 arthroscopy, only 4% of slap lesions and less than 2% were real slap lesions. And then became the error. So be careful with the slap lesion, because a lot of disasters that we see in the shoulder is people who fix slap lesion that were not slap lesion. Scapular dyskinesia leads and can lead to overload and stenotic synovitis. Without cuff tear, conservative treatment first, but no, don't take more than 3 months, although the patient wants. The patient is not in a hurry. 10 seconds. I always at my 10 seconds. I'm going to finish now. I'm sorry. So myself, between tenodesis and tenotomy, in most of the young population, I will go to the tenodesis. There are some cases that we have to do where it's easier to do a tenotomy. Maybe persons who are fat, has a very, very bad tendon, and together with some sort of a repair of the cuff. It's an optional articular, suprapectoral, subpectoral. My preference goes to subpectoral, which I have a lot of experience, but the literature said that the results are similar. There is no statistic significant in all those cases. And my point is that most of those patients who get rid of pain after a suprapectoral is because you release the transverse ligament. So that's why the results are going to be good. Do what's best in your hand. And I am a biceps killer. It doesn't mean that you guys have to be a biceps killer. Okay, thank you very much. And one more time, Adel, so I'm very pleased for being here again. And Mohammed, thanks for always.